One is live, and we are live. Vikram Talaulikar, welcome again on a Saturday night. What more would you want to do than sit on social media and talk about guidelines in menopause? But we do have a number of them that are new and interesting and different. So shall we have a look at them? I don't think, as you quite rightly said to me earlier, we're probably not going to get to endometriosis because these other ones are fairly meaty. So we shall do that at a different date. But we will start with the cardiovascular disease recommendations, because these are actually really kind of interesting. And as we know, cardiovascular disease, depending on which country you're in, is one of the biggest killers of women. And there's been a lot of confusion about whether or not people should or shouldn't have HRT if they have had a heart attack or a stroke or have very high risk factors. So I guess, what is it that would make people worry about having HRT in the first place if you've got or had a heart attack, coronary heart disease, or had a heart attack?
So I think most of the risk from cardiovascular health perspective is about having repeat heart disease. So if you've had a heart attack, you can have another one. Also, it goes hand in hand. So if you've had heart disease, you're likely to have atherosclerosis, you're likely to have an increased risk of blood clotting, and that would again increase risk of stroke. You're also more likely to have background diabetes or high blood pressure or high BMI, obesity. So all that goes together to say that metabolically, you're high risk if you already have cardiovascular disease. And that often in context of HRT is viewed as a problem, because traditionally HRT has been viewed as oral HRT, combination of oral estrogen with a synthetic progestogen. Now we don't look at it that way because we've got much better preparations. But if you look at traditional HRT, the problem was it would induce risk of blood clotting. It would not be so good for your lipids and your cardiovascular profile because you had synthetic hormones. And so the two did not go together. You had a high risk of cardiovascular disease. You're taking something that's likely to increase your risk of blood clots and worsen your lipid profile or diabetic status. Don't take it. Used to be a general thought. But as we know, everything has changed in the past 2 decades. And it's a good thing that these guidelines have come out, because as we talked on our previous webinar, the NICE guidelines did not give enough weightage or did not explain this clearly enough about the difference in cardiovascular risk when you take HRT early. Also, what is the current thought about the different formulations when you have established heart disease. So it's good to see BMS come out with these guidelines, and hopefully we'll talk through them as we go along.
All right. Now, how much? I mean, you talked about changing evidence and why things have changed. Or, they have changed over the last decade or so. But when you look at this, it's 23 randomized control studies that were in this, and only 6 of them are on transdermal. So how much weight can we put into these?
Well, I think significant data. It's not as much as you would love to have. As I said, evidence is never enough. You can have more, you can have better quality studies, you can have larger observational data, you can have more RCTs, but we know research is really difficult to come by because of funding, because of resources. It takes many years. Given that these data are based on sufficient number of observational studies, RCTs, although yes, small size and they are minimal in terms of transdermal HRT, the data are significant, sufficient for us to conclude that for most women, the transdermal HRT in a dose that's the least effective dose is sufficient to give them protection in terms of the CVS protection if they start early enough, and not likely to worsen their outcome if they take it after, even though they have established cardiovascular disease. So evidence-wise, happy with it. You can always ask for more, but what we have got is good to rely upon.
Okay, so the 2 main recommendations, just sort of going through them to be sort of clear, because you're breaking up a little bit. The first one is that low dose estrogen is okay for ischemic heart disease. And the second one, which is I guess when people had a heart attack before, people instantly wanted to stop them. The second one is saying, don't stop HRT after you've had a myocardial infarction, but best to use transdermal. So are we confident and happy that people will be able to adapt this to their practice, and how would they?
Well, that's the intention. And again, this is about awareness, education, that the previous thought that was linked to risk of cardiovascular disease and HRT now needs to change. The attitudes need to change, and that is why the evidence is now starting to come out. As you made notes, I've made a few notes, so let's go through them one by one, and then I might come to some of the points you've raised already. So before we go through all the guidelines, again, as you pointed out, evidence may be limited in certain areas. As you pointed out, for example, only 6 RCTs for transdermal, or as we come to cancers, there is very, very little data about actual trials in women who have had cancer and are taking HRT, very short sample sizes, very limited follow-up for 2 to 5 years. And so evidence has limitations, but we are going to hopefully concentrate on the existing evidence and take you through. The good thing about the guideline was that they did mention that for a woman who is not at risk so far, has not already had cardiovascular disease, if you start HRT within 10 years of menopause or under the age of 60, you have a favorable benefit to risk profile. And that's important to stress because this was not covered in the NICE guideline. If you start HRT early enough, yes, it's not meant to be started just for preventing cardiovascular disease. It's a treatment for symptoms of menopause. But you get a side advantage is where you will have less incidence of heart disease in your future life if you start HRT early. And that is an important point when discussing whether to start HRT or not. The second one, it's not an absolute contraindication for many patients, including, as you alluded, people who have had MI or heart disease. So in HRT world, it's not an absolute contraindication. Women may choose to take HRT even if they have already existing cardiovascular disease or have had an MI, because for them, if the symptom suppression gives them a quality of life and they're prepared to take a slightly increased risk from HRT, it would be their choice. So here it's patient choice and a shared decision with the doctor. That is critical. There's no absolute contraindication. The third one is about transdermal estrogen. So throughout the guideline you read, the recommendation is to stay on the lowest effective dose. Transdermal estrogen or estradiol is the best. So whether you use a patch, gel, spray, doesn't matter. Transdermal estrogen, which bypasses the liver and the gut, does not have an increased risk of blood clotting, seems to be the best from cardiovascular perspective. The progestrogens, avoid the synthetic progestrogens in somebody who already has heart disease. And we've known this for a while. You either use the natural micronized progesterone or the dydrogesterone, or you could use the Mirena coil, although it's synthetic, because it largely avoids systemic absorption. That would be your third choice.
So when you say that, because yeah, that's we're avoiding the androgenic type progestins. Is that correct?
Correct. So the androgenic type, the norethisterone, the MPA, the hydroxyprogesterone acetate, you don't want those typical traditional progestrogens as far as possible, because they are linked to worsening glycemic profile, they are linked to worsening lipid profiles and have adverse impact on cardiovascular risk, while these ones are neutral. The dydrogesterone, the micronized progesterone don't seem to have the same action.
And because the Mirena coil is sort of acting locally, it's not as great a risk either.
That's right. So it's local. It doesn't seem to increase risk of thrombosis, minimal absorption into circulation. Yes, there is absorption. That's why we still attribute breast cancer linked to it. But thrombosis-wise, it doesn't seem to increase the risk of thrombosis like the oral synthetic progestrogens. There's also a mention in the guideline about concurrent statin. It is seen in many of the studies that statins, in addition to HRT, give advantage, especially after you've already been diagnosed with cardiovascular disease. So that's a consideration, because there is a lot of opposition to statins in the world.
I've got this here who's starred as one of my main questions, because at the moment, as I don't know how aware you will be, but on social media especially from quite a large of quite popular and influential menopause doctors, basically the message is statins don't work in menopause. But this does seem to completely actually overturn that thought, because there were two things here that were very impressive that stuck out. Were statins and HRT together decrease the risk of clots by 55%. That's pretty significant, I would have thought. And HRT, while it has improves your LDL, your low your bad and your good cholesterol profiles. It also seemed that if you had the HRT and statins together, you got an even better result.
Yes, and that's why, again, the point about statin is go by your GP's advice, go by your cardiologist's advice, because the statins will have a role. They are non-hormonal therapy for cardiovascular disease prevention. HRT is great. We know it helps with the blood vessels, the heart, the suppleness of the blood vessels, but both could be even better than just single therapy alone. And again, that's not advice generally for everybody. It will depend on your background risk factors, your cholesterol levels, your genetic tendency for cholesterol, your age, your BMI. So many factors will determine what's personalized best for you. The statins, HRT, both. But again, you can't remove it out of equation thinking it doesn't work. There is a difference in how statins work for men and women and for different individuals based on their genetic predisposition. But at the end of the day, it's one of the valid options which you can take alongside HRT, does seem to benefit certain groups of individuals. Yeah. And then finally, it was don't discontinue following MI. As we said before, myocardial infarction, don't discontinue HRT just because somebody has had an MI. Try to consider the lowest dose transdermal estrogen, a better progesterone if they're not already on it, like the micronized progesterone or the dydrogesterone. But again, individualization and not abrupt decisions thinking this should be stopped. That is the key. You will still have women who may be asked to stop because there may be risk of high blood clots. They may be, particularly because of their individuals' multiple comorbidities, may be better off stopping while they are being investigated and treated for an acute event. I do support that, but it doesn't mean you abruptly stop for everybody. Once the acute event has been managed and the investigations have been completed, they can certainly go back straight to starting their HRT again. So that's about MI and not discontinuing just as a general rule for everybody.
Random question, actually, because actually I just remembered that somebody sent this question and speaking about stopping things. They said, why are they being told to stop taking HRT before an ultrasound for bleeding, for unscheduled bleeding? I've never been told to stop mine. Why would you have to?
So that's an option. It's not a mandatory thing to do, that you should stop your HRT before going for a scan or assessment of the endometrial thickness. Some women can be given an option to stop HRT for 4 weeks to make sure that they've stopped bleeding and then restart HRT. It's one of the ways you manage the unscheduled bleeding. You don't have to do that, because when you stop HRT, you can come off with symptoms and it may immediately impact your quality of life. So you can continue taking it, have your investigation, and then decide what the change for HRT should be. There's no rule like that. Yeah.
The very lovely Dr. Kara Sonnenberg is adding over here. She's saying, can I add that for secondary prevention, lowering lipids, especially LDL, is so important. There are a range of treatments and statins are one group. The LDL targets are low. Yes, it is people don't pay enough attention to these things, especially around menopause. They don't. Which leads me then, actually it doesn't. I'll come back to it because I will ask you the one last question I had about these before we move on to the window of opportunity. And that was palpitations versus atrial fibrillation. Now, a lot of people get very, very confused with this. But in general, what's the difference between a palpitation and atrial fibrillation? And what's the role of HRT in the two of them, according to these?
You're asking the wrong person. I'm a gynecologist, not a cardiologist. So I think I would say palpitations are a common symptom of menopause. Palpitations can happen as part of menopause when estrogen levels decline. And of course, for those, often HRT does take care of that. So the palpitations often seem to much more become less, or sometimes even disappear completely when you institute HRT. And other ways of managing palpitations can be beta blockers, for example, especially if they're associated with anxiety. You're an anxious person, palpitations worsen. Beta blockers is yet another option that's often used in the primary care. What is important is to diagnose arrhythmia. Arrhythmias are often recurrent. They can happen and cause episodic other symptoms in addition to the palpitations or fluttering of the heart. For example, the blood pressure may change. You may get dizziness. And those sort of other cardiac sequelae may happen alongside the changes to the heart rate and rhythm. You often may have a previous diagnosis already, or maybe diagnosed for the first time in life when the first episode happens. And that's much more significant than the palpitations which happen as part of the just menopause transition and level of estrogen decline. Again, that's a risk factor for having stroke or emboli or blood clots. So the more important bit about AF is if you've been diagnosed with AF or atrial fibrillation, you are at a high risk of having another episode and blood clot. So you should be seeing your GP as well as the cardiologist, whoever is your doctor who is taking care of AF, to make sure you're on the right medication, right preventative strategies so that you don't have arrhythmia episodes.
Yeah.
And that in the context of the stroke as well, because when you look at the stroke being addressed in the guidelines, it does actually recognize that stroke is quite a wide term to cover different pathologies, different terminologies. You have different types of stroke and different etiologies of stroke. And often when HRT has been studied in relation to stroke, you don't have specific data for each condition or each type of stroke. It's often all put together. And often these are again studies with oral estrogen and the oral MPA, the medroxyprogesterone acetate. These dominate most of the studies. And how reliable are those data to today's HRT? Comparing the two, not much probably, because the current HRT is often transdermal if you're suspecting somebody is at risk of stroke. So with anybody with stroke, as the guideline says, remember that the underlying factor control is important. So control of blood pressure, hypertension. Age is the most important factor giving risk of stroke. Again, control of things like diabetes, that would be again part and parcel of controlling risk. And then individualizing. So if you've had a stroke, individualizing the type of stroke you had, what was the risk factor. You can still have transdermal estrogen, micronized progesterone or dihydrogesterone. For most individuals, that would still be a feasible HRT as long as you're addressing the underlying cause. That's the important bit.
All right. Now, you mentioned age there, and as we know, there's been a bit of chatter around these days about a recent paper that came out saying, should we review and change the window of opportunity, which you also mentioned a little bit earlier. So I spent this morning actually watching a debate between Susan Davis and Mary Lumsden, I think her name is from Glasgow, quite a significant person in the menopause world from up that end of the earth. Debating whether or not it should or shouldn't be. And basically, in the end, the theory was that we've probably got enough good evidence now to say that maybe not, carte blanche, but, to extend that window of opportunity into the 60s to 69 wouldn't necessarily be a bad thing. What do you think?
Yes, I think we've been saying that for a while. Of course, the guidelines can't recommend this right now because, again, evidence-wise, the guidelines have to go by huge amounts of good evidence. And once the guidelines are out, it's applied to everybody. So they have to look at the practical implications of how effectively the guidelines would be actually applied. But in terms of scientific or evidence-wise that we have for woman-to-woman personalized medicine, I think the arbitrary cutoff of 60 and you can't start it after 60, or you can only take it to 65 and you cannot take it after, those sort of arbitrary limits don't make much sense because there will be lots of women who could still benefit from symptom control, quality of life, bone osteoporosis or fracture prevention, cardiovascular health, still having good enough benefits for heart, blood vessels, lipids. They will still continue to have those benefits in their, say, 7th decade of life. So as long as a discussion is had why we think that that particular individual is likely to benefit more and have less risk in terms of thrombosis with the better transdermal preparation, or they are doing everything they can to reduce their breast risk and having monitoring, in that situation, the benefits still outweigh the risk. So person to person on an individualized basis, I think HRT guidelines currently are very restrictive. And there is a role to open it for more people, even if you start late or in your 7th decade of life.
Yeah, and it was the bone health that was one of the major things actually in that debate that they were saying in the end. It sort of, Susan Davis's argument was basically, why wouldn't I give somebody HRT if it's a choice between a bisphosphonate and HRT, the bisphosphonate is going to, while all drugs have their risk factors and things, if you've got a limited life on a bisphosphonate, why wouldn't I give them HRT first, and then if we needed to add that in
Leave
later
it
on,
for the last.
logic.
Correct.
Yeah.
I think it makes
Yeah.
sense. I mean, all of us working in the repro endo clinics often find HRT is the best medicine for bones if required. So if lifestyle is not enough, you've got added risk factors, really, HRT can help you with bone much better than many of the non-HRT medications, which have their complications after 5 years or so. And the newer agents we haven't studied well. There are some new non-HRT bone medications, but we don't have enough experience and data with them. So I guess it will happen. We'll get in the next 5 or 10 years, guidelines will change to reflect this, that on an individualized discussion basis. And if the woman considers the risks to be low, you can offer HRT to more people after 60 and for longer. We can see that already happening, but the guidelines will, I think, accept that gradually in the next 5 or 10 years.
Yeah.
Just to finish the cardiovascular bit. So we talked about the AF risk after arrhythmia. So again, HRT is fine after most cardiac arrhythmias, except if somebody has risk of atrial fibrillation. It's important to manage this because the guidelines cite one Korean study saying HRT could increase risk of atrial fibrillation. But it's one study, it's observational data, so you can't really rely on that. General principle would be, if you're managing risk of your arrhythmia and stroke, trying to do everything else best to control your high blood pressure on your medications compliant, then HRT can be offered on an individualized benefit risk discussion. Congenital heart disease, again, individualized. There are some high-risk congenital heart disease condition where you may have to look at risk of pulmonary hypertension and a few other important bits which may contraindicate use of hormones. But generally, in most sort of situations, you can have individualized HRT. And they mentioned about impact of HRT on something called QT interval in the ECG findings. Again, HRT can impact this interval, estrogen or combined, the impact in a different way. Important to have that discussion with the woman and liaise with her cardiologist in some of these uncommon or rare conditions related to the heart. The one condition where they often say avoid HRT is the coronary artery dissection, spontaneous coronary artery dissection. It's an uncommon condition, but I think it's important to mention that the guidelines say, based on pregnancy data, this is thought to be linked to hormones. There's no evidence that hormone therapy can do it, but they advise caution because in pregnancy, the risk of coronary artery dissection can increase. So that, I think, will finish our cardiovascular guideline. Oh no, I missed one. Heart failure and cardiomyopathy. So heart failure, the guideline says there's poor data about HRT and heart failure and menopause. But I must say they've missed out on cardiomyopathy here. Cardiomyopathy patients are occasionally referred for consultation about HRT. And with heart failure, cardiomyopathy, fluid shifts can be very significant. Both estrogen and progesterone can draw in fluids, cause fluid retention. And patients who may have just recovered from cardiomyopathy or are in a delicate fluid balance can have a shift of fluid balance if you give them too much HRT. So again, important here that we don't miss out the fluid balance and the hormone fluid shifts that can happen. So be very careful if you do have to give HRT following cardiomyopathy and heart failure. That would be the only sort of extra bit. And you will like the guideline because it says vaginal estrogen is fine in all these conditions. So you can safely prescribe all vaginal estrogen with any heart disease. That should not be denied to anybody.
Excellent.
Okay, that's it on the first one from me.
Brilliant. All right. And then now, POI, premature ovarian insufficiency. I will admit I have not read this one, so I'm going to leave you to entirely just race through.
Okay. Well, luckily there is not too much extra new information. So we knew POI guidelines came from ASHRI some time back, and it's got an update now. And they've done a brilliant job with POI guidelines. I really like the guideline. It's a term that's premature ovarian insufficiency. That is what we should be using. You can have iatrogenic, which means medically or surgically induced POI, or you can have non-iatrogenic, which is usually the immune, the genetic, and the unexplained POI that can happen. They really stress on using this under the age of 40. 40 to 45 is early menopause. We know that. The diagnostic criteria have remained the same. So you should be having oligomenorrhea, generally periods less than 4 months, more than 4 months apart. You should be either having amenorrhea or oligomenorrhea. Then you should have a high FSH of 25 on at least 2 occasions, 4 to 6 weeks apart. Low estrogen can help with diagnosis, but not mandatory. And then, of course, you have the AMH. So don't use AMH to diagnose POI. It's not a hormone that can tell you about POI. All it tells you is that the ovarian reserve is low. It can help with fertility counseling. It can point towards the diagnosis of POI, but don't use it as a diagnostic marker because it needs to be carefully interpreted. Prevalence-wise, it's thought to be 1 to 3.5%. So we know in some groups, for example, Southeast Asia, it does appear that the prevalence of POI is higher as compared to, say, Caucasian population. And that may have many reasons why it's high, genetic or environmental. It does focus on counseling, which is really important. A lot of healthcare professionals still don't provide counseling. The diagnosis of POI is often given in a very non-sensitive manner. Sometimes on telephone, which can be quite terrible for the patient. They need counseling, they need psychological support. You need to refer to whatever services you have available or signpost them to organizations like the Daisy Network or Turner Syndrome Society. They will often help a lot in the process. What kind of investigations are recommended? So anybody who wants just a quick rundown, if you're in the primary care, you're going to do the standard bloods, the FSH, LH, estrogen. You might do thyroid prolactin to rule out other causes of amenorrhea. And then once you know that the FSH is high, there's low estrogen, the history fits it, you're going to straight away refer to the secondary care or a specialist clinic. In the meantime, you could offer the psychological support and the HRT if you feel confident. In the hospital, we will do a karyotype, which is now recommended for everyone. That's the genetic chromosomal testing. Also recommended is a Fragile X syndrome test to look for Fragile X mutation. Those are the two common genetic causes, the Turner's and the Fragile X. In fact, the guidelines even go so far as to say if you have the facility and it's available, you can offer next generation sequencing, genetic sequencing. And that's to pick up more genetic causes. Because we know that at the moment, out of those 80% where we don't find the cause, many women will actually have genetic mutations and changes. We don't have the tests and the resources to catch those, but it would be nice to eventually actually offer a diagnosis and pick up genetic mutations. But what we have to keep in mind is they will need genetic counseling and a backup support. So doing it and then leaving them is not the idea. You have to have a backup genetic counseling support. And with the resources right now, that's not possible. So we often stick to the karyotype and the Fragile X. Immune cause, it says about adrenal antibody testing, the 20-fen-hydroxylase. We used to traditionally test for 3 antibodies, the thyroid, ovary, and the adrenal. It doesn't recommend the thyroid and the ovarian antibodies. And therefore, adrenal antibodies are the focus of this particular guideline. It says that if they're positive, they need endocrine surveillance and testing for adrenal function, because in future, they could go on to develop adrenal insufficiency. It does mention about thyroid testing once every 5 years. That's because you're likely to have hypothyroidism in future life if you have POI, and that's important to address. And then it moves on to treatments and fertility. So I won't dwell too much on that. We know HRT is the gold standard here. For a woman diagnosed with POI, giving hormone replacement until the age of natural menopause, which is 50, is the critical bit. And you can, of course, work on lifestyle, the vitamin D, the calcium in diet, the weight-bearing exercise, the training and the resistance for muscle and bone, keeping healthy diet, avoiding smoking, limiting alcohol. They are all equally important, but you can't deny that HRT here makes the difference, because it will improve quality of life, protect from osteoporosis, prevent cardiovascular disease. This particular cohort prevent dementia risk in future. And all those benefits are against very little risk, because the HRT is actually not increasing risk of breast cancer purely because of taking HRT in this cohort of women with POI until the age of 50. So you have lots of benefits and very little risk from HRT. So that's really the gold standard here. And then it recommends about monitoring, making sure these patients are seen once a year for blood pressure and weight, making sure they have a DEXA scan every 3 to 5 years, depending on how good their bones are already, making sure they have follow-ups. And this is something that I'm fighting for. There's a trend for one-off consultations and discharge to primary care, and often primary care cannot see them because they're already flooded with patients. These patients get lost in the system. We need good monitoring follow-up so that we're looking after their lipid profile, we're looking after their bones, we're looking after their heart in the long term. That's not happening universally right now. Finally, it talks about the sexual function. Some women may have issues with sexual function. So again, psychosexual approach, biopsychosexual approach, and testosterone in some women will be important to consider. And that's about the treatment side of things that the guidelines talk about. Final point is about induction of puberty. So women who are diagnosed very early in life to not to have spontaneous puberty, the traditional treatment that was often given to induce puberty was contraceptive pill. We don't recommend it as first line now. It is much better to give them estradiol and then introduce progesterone after 2 years or once they start bleeding. And it gives a nice sort of bit of paragraph and page on that about how to induce puberty according to the current guidelines. So anybody working in the field and dealing with this, it's really worth reading the POI guidelines for that reason.
Okie dokie. Is it, yeah, that I had a message the other day from a woman who went through POI at 33 and was having all of those people, you know, the whole thing. But I don't know why you need to go on HRT. It's natural. But when you go through and you put all of those things with the bones and the dementia and the heart risk and all of those kinds of things together, you can see why it is especially important for somebody who's gone through it at a very, very early age.
That's really important. I think the message has to go out there. Unless you have a contraindication, you have a hormone-dependent cancer, and even sometimes in those situations, one has to take a benefit risk approach, and HRT may sometimes be indicated. But let's say if you have a contraindication and you may not be able to access HRT, that's very rare situations. But for all others, HRT is absolutely the game changer, at least until the age of natural menopause. And then it's your choice. You want to carry on or you may want to come off gradually.
Yeah, all right. You have a question over here, which is, would you please talk about DHEA, and I'm assuming this is pregnenolone she's put there. Any new meds for premenopausal sleep latency?
No, so I'm not a sleep expert here, and I certainly don't use pregnenolone or DHEA for any of my menopause patients. There was a Cochrane review some time back using systemic DHEA. So I'm not talking about vaginal DHEA, intrarosa here, that can be used for vaginal symptoms. But systemic DHEA, which is a precursor of androgens and estrogens, that is the review did not note any benefit with effectiveness for menopausal symptoms. There were some concerns about hyperandrogenic or androgenic side effects, and there are no long-term safety data specifically using DHEA for menopause. Pregnenolone, same. Again, it's used in bioidentical custom-made HRTs. I don't use it. I have no experience. I don't think there are any long-term safety efficacy data more than 5 years with it. So I wouldn't recommend either of them for menopause reasons.
Yeah, all right. Gynaecological cancers. Now, this was huge. This was a very, very, very long set of guidelines. So, do you want to go through each different cancer one by one, or how do you want to attack this one?
Okay, so the first thing is, it's great to see the guideline. It was long awaited. I think there was a parallel Lancet paper, which also came about menopause and cancer from a series of Lancet papers at the time, just before the guidelines were published. And both of them use this approach of red, amber, and green sort of signaling approach, where you can use HRT and you cannot. But it's useful to see these guidelines because there has been a lot of confusion over the years, both for GPs as well as for hospital specialists. Where can I use HRT? Do I have to let the patient wait for 1 year or 2 years for her to be seen in a very specialist clinic, by which time patients suffer, where they could have easily had a HRT? So really, this kind of bridges the gap now. Many gynecologist specialists will be, I think, confident using these guidelines to start HRT. And then if they need referral for further discussion, they can, of course, be referred to a specialist clinic. So I'll try to share my screen so that you can probably see the table as I go through it. And that will be the best thing to do. Okay, can you see my screen?
I can, and let me add that to the stage. There you go, look at that. Easy
Okay, good. So I think I'm focusing right on the table because we know that for many women who are going to have cancer treatment, both the POI guidelines as well as the BGCS guideline, first of all, recommend on having that discussion before treatment. And this again was part that was missed in many of the guidelines before. Certainly, there's a need for guideline on surgical menopause because often discussion about what is going to happen when ovaries are removed, what is going to happen about fertility or hormone symptoms and impact on bone, heart, and brain does not happen routinely whenever cancer treatments happen. And so that has to happen first. A pre-op plan has to happen about hormones, if required, fertility preservation. And then, of course, you move on to go ahead with the treatment and then institute the hormone-related plan after the treatment has been completed. So that is the first part of the guideline, focusing on pre-operative or pre-treatment counseling. And once the patients are ready, they've gone through the treatment, they can be offered lifestyle, non-HRT, and HRT for menopause symptoms. We won't talk much about the non-HRT and the lifestyle options today because we have covered this in previous webinars. It's mainly the general lifestyle advice, as well as things like cognitive behavioral therapy, hypnotherapy, alternative therapies, as well as some of the non-HRT pharmacological therapies, the gabapentin, oxybutynin, clonidine, and the SSRIs. So we won't talk about that. Those are for women who cannot take HRT. And of course, the new drug, which is the fezolinetant, may be useful in some women who've completed their active treatment of cancer. But let's focus on HRT because most people want to know, can I give HRT after a particular cancer? So the good news is for most gynecological cancers, you can offer HRT. It's certain subtypes and certain specific type of cancer where caution or contraindication is advised. So if we start looking at the ovarian cancer first, so that's going to be the ovarian, fallopian tube, and primary peritoneal cancer. You can see that systemic HRT, systemic estrogen alone or estrogen progestogen, if you look at the various cancers, if it's a high-grade serous cancer or a low-grade serous stage 1 cancer, it's often amber. So you can offer HRT, but based on a personalized benefit-risk discussion, involve the oncologist, and then you could offer it. But if it's a low-grade serous cancer of stage 2+, then it says it's contraindication because these tumors tend to be very sensitive to HRT. So try and avoid it. Even for vaginal, there is an amber there. So you would only really use it if non-hormonal therapies had not been successful in treating GSM and the patient accepted certain element of risk. But otherwise, vaginal estrogen is completely fine for all other ovarian type of cancers. Again, it's green or amber for all the other endometrioid or clear cell or mucinous or germ cell tumors. The only place where it becomes red or contraindicated is a granulosa cell stage 2+. Now, clear cell tumor and granulosa cell tumors of ovary, again, there remains lack of consensus. The guidelines help because you can offer HRT. Unless it's granulosa cell stage 2+, you can offer it on an individualized basis. Some guidelines still say clear cell, granulosa cell, we don't have enough evidence. They can be hormone sensitive, so generally contraindicated. So make that decision with the oncology team in a sort of MDT situation. Borderline tumors, again, with no residual disease, it's green. You can offer HRT. And for those with peritoneal implants or recurrence or microinvasive disease, it's amber. So only if benefits outweigh small element of risk. If we go down to endometrial tumors.
Just go down,
yeah.
just scroll back up to 1 second to the serous stage 2 with the amber next to it. This may be a very stupid question, but that's what I'm here for. Is then prasterone or aspemifene or are these other types of things alternatives that you could offer then or not?
So in terms of the vaginal, you mean? The
Yeah.
vaginal estrogen? Yes, you could. So again, there are no specific studies in, let's say, low-grade serous tumors of ovary where women have been given vaginal therapies such as the progesterone or have had ospemifene and have been followed up to see what the recurrence rate is or what the impact of these therapies are. So it's all going to be off license, more or less like we say for breast cancer women, where they've had breast cancer and we are using either Interosa or ospemifene as off license when the vaginal estrogen is not possible to be prescribed or not desired. So you can give it on a case-by-case basis, and those are the options certainly if vaginal estrogen is not to be used, but the data are missing. There are no big data to give us scientific evidence of how safe and effective they are in this particular group of patients.
Cool.
Then we move on to endometrial tumor. So early stage and low risk endometrial tumors are usually cured by hysterectomy and bilateral salpingo-oophorectomy. So again, it says low intermediate risk. You can offer both systemic and vaginal HRT. High intermediate risk, and again, it kind of specifies them as per the receptor negativity or positivity. And it will say amber for those two groups of patients. But if it's a high risk patient with ER/PR positive, it says systemic HRT is contraindicated. Similarly, for advanced or metastatic endometrial cancer, it's contraindicated because the estrogen may bring your tumor back or worsen your prognosis. So for most patients, you'll be able to offer HRT on an individualized basis with benefits risk. Vaginal estrogen, the same here. The concern with endometrial tumors after hysterectomy and vaginal estrogen is when you insert a pessary or cream vaginally, there may be high local concentration of estrogen around the vault where the hysterectomy was performed. And that might give you some sort of a negative impact in terms of your chance of recurrence in future. And so often vaginal estrogen, especially for endometrial tumors where hysterectomy vault is concerned, that seems to be a point of contention. Again, people vary in opinions. Some people will say systemic HRT, and that might be better than a local vaginal estrogen, but there is lack of consensus. If you stick to the guidelines, it will say use it if the non-hormonal therapies are not useful, and if benefits outweigh risk. I have explained to the patient the lack of data. You can use vaginal estrogen in those situations as an amber, but certainly systemic HRT for high-risk patients, try and avoid. Now, in this particular situation, you can also use progestrogens on their own. So remember, endometrial tumors are sensitive to estrogen, but actually progestrogen counteracts that. It suppresses endometrium. So just high dose oral or transdermal progestrogen. Of course, we don't have transdermal good preparations, so it's likely to be oral. So in that situation, you can use the progestrogen alone on its own, can sometimes suppress hot flushes, some sweats, and also will improve quality of sleep. So you can use it as one of the options if estrogen cannot be used.
All right, my next stupid question then that comes off the back of that is just in case, if people were considering testosterone, what would happen then?
So the testosterone is to be looked at as if you're giving estrogen, because remember, a significant amount of testosterone will be converted to estrogen in the body. So for whatever you say, amber or green for estrogen, the same thing applies to testosterone. If it's a red or a contraindication for estrogen, giving testosterone is not far too different. It will convert into your body to estrogen, and then of course it's contraindicated, so you can't use it. Now, you could argue that can I give aromatase inhibitor alongside testosterone because that would prevent the conversion. That approach has been used in some centers, but it's very sort of a single center experience or two center experience where they've tried to use estrogen with an aromatase inhibitor for breast cancer patients and reported successful use with no increased risk of recurrence. But we can't go by just one or two center data. We need more evidence to suggest whether such approach would be useful. And again, aromatase enzyme varies in various tissues. The activity will vary. So it doesn't mean that if you can't see blood levels of estrogen, that in individual tissues, there might still be estrogen conversion from testosterone, which may increase your risk. So far, the same rule applies to estrogen and testosterone.
All right. The other thing that I thought was interesting when I was reading this was the if you're on tamoxifen for a breast cancer and to also consider what it's doing to your uterus.
Yes, so again, tamoxifen is known to increase the chance of endometrial hyperplasia because it does proliferate endometrium. Sometimes that has been counteracted with things like Mirena coil to try and prevent hyperplasia from happening or treat hyperplasia that does happen. And so again, that's always something that we consider in terms of any bleeding once tamoxifen has started. Yeah.
All right, good.
Cervical, vulval, vaginal cancers. So these are all green, green, green. So if you've had a cervical cancer, vulval or vaginal cancer, they are largely don't respond to hormones. In fact, vulval, vaginal don't respond at all. The cervical ones, there is controversy. So the squamous cell cancer, which is the more common one, is not hormone responsive. So most patients will be able to receive HRT after treatment of squamous cell cancer. If it's an adenocarcinoma of the cervix, there remains some controversy because there are reports where adenocarcinomas are sensitive to estrogen. They do have receptors, and there could be small increased risk of recurrence, especially if you use estrogen only HRT or estrogen vaginally. So some guidelines, not this one, still advise cautious use with adenocarcinoma. So they would put it as amber. If it's a cervical adenocarcinoma, try and avoid local vaginal use non-hormonal if possible. And if you're using systemic HRT, tibolone or a combination of estrogen, progesterone, so that progesterone suppresses estrogen action, those will be the best HRT for cervical adenocarcinoma. Finally, uterine sarcomas. Sarcomas are very hormone sensitive. Leiomyosarcoma, endometrial stromal sarcoma, very, very sensitive to hormones. These are definitely contraindications for use of hormone. We can use all forms of non-hormonal therapies as far as possible to try and alleviate symptoms. And these are two tumors where one would definitely not recommend going anywhere near the hormones.
Yeah. All
So
right.
that's good because the kind of table gives you a bit of stratification as to where you don't have to think about giving HRT much. Amber, where you have to kind of carefully weigh the benefits risk, have a discussion with the woman, look at what she's expecting from the treatment, and then have a careful discussion. And the red, where you will really advise patients not to go down the hormone route. So hopefully
Yeah.
that will help lots of specialists and GPs.
Or when you should advise them to go down it. I noted in there that they said that when they were talking about people who had a surgical menopause, I shall read this as a quote. It said their increased awareness of the significant health benefits for this patient group is needed amongst professionals and women. And they went on to cite a couple of number of statistics there were showing that less than 50% of women who'd had ovaries and uterus removed were given HRT, and that the compliance that most of them who were on it then were actually not even taking anything that came close to a recommended dose, which is a little bit sad really for those who are able to take it after a cancer but then aren't actually getting the information that they really need, which goes very
Absolutely.
much to Diane's survey the other day of women who'd said they'd been not given any information and not given any treatment.
I think it all talks about the same, isn't it? Is that the survey told us that currently the clinical pathways for patients with cancer or without cancer having surgical menopause is not effective. Most patients don't get the pre-op discussion about impact of lack of hormones and what can be done after the operation or surgery. They don't know their non-hormonal and hormonal options for treating various symptoms that may happen. Often the impact of bones, need for surveillance, impact on heart and dementia risk for younger women who are below 45, that's never a part of pre-operative discussion. So we need to keep going with these efforts, develop guidelines, guidance, keep going with educational webinars, awareness sessions for different health professionals. Because unless we get the message out that HRT has changed, it's not the only thing in menopause. Of course, there are many other alternatives, but for many women, that is likely to be the game changer, especially if they are below 45. And for others, it has benefits risk, which for most will be favorable. So they have the option of it. And that's often delayed or often misdiagnosed, which is what we don't want to do. We want to keep going for better access.
True. And the other thing that I found interesting was that, especially when it came to vulval cancer, they actually mentioned in there that after treatment, local estrogen can actually help with the healing of a vulval cancer. Not a melanoma one; it was a neutral result, but for other forms of vulval cancer. The other thing
Yes.
I thought was that's worth actually running through, just to make sure that people are sort of clear. In these cases, again, should it be transdermal? Does it matter if it's oral? Does it matter if it's a synthetic or a progesterone or a progestin? Does it matter?
No. So I think the principle here is giving HRT means you're giving estrogen, progestogen back. For those who don't need progestogen, let's say they've had a hysterectomy, there's no evidence of any endometriosis or previous endometrial type of tumors, you can give just estrogen. For those who have a uterus in place and have had endometriosis or endometrial type cancer, it's going to be combination of estrogen, progestogen. Which one you choose will depend on other factors. Is there a risk of thrombosis? Or actually that patient is young and will do better on oral because they will comply better. So a lot of things need to be considered. Younger patients tend to comply better with oral combinations or estrogen. If they don't have any risk for thrombosis, that might be your best bet. Women above 45 or 50, you generally tend to err on the side of caution and say transdermal estrogen, and estradiol is the one that's universally used. And then you can combine that with a more favorable progestogen, like the micronized progesterone or the dydrogesterone or the Mirena. And even for younger women, when you're using oral estrogen, you get very favorable combinations with micronized progesterone or dydrogesterone now. So you can offer it. You'll have the occasional patient who may have a lot of bleeding issues or sensitivity to certain progestogen, then you can use synthetic progestogen as long as you've had a benefit risk assessment, there's no risk of thrombosis. Many young women may still benefit from combinations with progestogens which are synthetic because they're better at bleed control. So it's really your patient profile that will determine which combination hormones you use once you've decided to embark on HRT.
All right. Tibolone?
Yes, very good. Again, there is a lot of controversy about tibolone. It's not a first-line HRT that we often use. We tend to go for estrogen, progestogens first. But in specific groups of patients, especially those with fibroids, those with troublesome endometriosis and having had treatment for that, those with sensitivity to progesterone, can't tolerate natural progesterone or can't tolerate many of the synthetic progestogen, pelvic pain, chronic pelvic pain, adenomyosis. Sometimes when all other HRT first line don't work, tibolone does the trick. And especially for cervical adenocarcinomas where you want to avoid settings like estrogen, tibolone has the biggest experience in terms of the usage following cervical cancer when the uterus is in situ. And often for us, unless there is a thrombotic risk factor, that's the first line for cervical adenocarcinoma treatment. So it has its role, quite useful for certain specific groups of patients.
Continuous versus sequential?
Again, that depends on patient profile. So if the uterus is in place, again, if it's a younger patient may prefer to have sequential HRT. Most of the gynecological cancers, you would have had a hysterectomy. So that becomes less important. You're going to replace estrogen. And as I said, you're going to give progestogen where you think there is endometriosis or endometrial type of tumor. But if the uterus is in place, it's best to give continuous combined. Avoid sequential following cancer. Why? Because again, you don't want these patients to continue bleeding longer. Bleeding often causes panic, whether the cancer is coming back. You also don't want somebody with a radiated uterus who's got uterine irradiation, radiotherapy, pelvic radiotherapy. Often the uterus shrinks and the cervix becomes stenosed. So if there is bleeding, it can collect and cause a collection, and a uterine collection can be painful, needs a drainage, and can cause infection. So it's best to go for a bleed-free HRT so that you don't allow the blood to collect. That's what we do if there is a radiated uterus.
That makes perfect sense. My final question for you is, they talked about non-hormonal things there, and one of the things that struck me were two things really, were that basically the vast majority of non-hormonal things are absolutely fine, but there are a couple of things. They're phytoestrogens and St. John's wort. What did you think of those?
So again, I think there is no consensus over. Some guidelines completely recommend to avoid phytoestrogens or St. John's wort. Others seem to have no problem with them. As a general rule, phytoestrogens come from diet. As long as you are taking them through dietary route, they should not increase your hormones levels to a point that it affects your recurrence. So you're safe to consume phytoestrogens within the moderate amounts that are usually what is part of a healthy diet. In terms of the St. John's wort, I don't have any prescribing experience. We often look at these as there are no long-term safety data. And so we often say any of the herbal preparations or St. John's or others like black cohosh, we tend to say medically we cannot recommend them because we need better, good quality safety data.
Yeah, brilliant. I think they were worried about drug interactions with the St. John's wort and with the phytoestrogens. I guess they're saying go off and buy yourself a bunch of giant supplements and as a way of compensating. I don't have any more questions for you. I can't believe we've actually made it through all of that.
Yes, and we still have 4 minutes to go.
Good. There you go. Is there anything else that we didn't cover?
No, I think you can talk about these guidelines for hours, and we have limited time. We have 1 hour. So I think we've tried to cover the main highlights, point people to or signpost people to information that's in the guidelines. So if you come across a patient and you want some information related to certain heart conditions, POI, or the cancers, then you know where to go. These guidelines are very useful. There's also lots of information from other societies as well as other sort of institutions. Again, at the final bottom line, we'll leave people with its individualization. No one approach will be right for 2 people in the same situation. Whether it's lifestyle, non-hormones, or HRT, individualize. And as long as you kind of balance the benefits and the risk, and you've discussed them and documented, I think that's going to be the way forward with each individual patient.
Yeah, the interesting thing is, just as an aside, I mean, often in these cases, I'm assuming then there will be shared care. It'll be between you, your GP, and a specialist, or a menopause specialist, or whatever in between that sort of situation. Somebody was telling me the other day that then, you know, the decision was made by the medical side of that, and I was thinking there has to be a patient involvement in shared care. Surely you can't have shared care without the patient.
No, that's not definition of shared care. Shared care is patient gets the information from the health professional, the good side of it, the bad side of it, the risks, benefits, and in that particular context, what may be their recommendation medically is completely at the end of the day patient choice to decide what they would like to do. And then that's the shared decision between the person who is making the decision with the patient. And then that information can be copied to other relevant professionals. So whether it's a GP, whether it's a specialist in certain area, then that information is passed on to other specialists that decision has been arrived at. The patient is at the center. The specialists all revolve around.
Yes, because obviously you can't have informed consent if you haven't shared the decision making with the patient. So it kind of made no sense to me. But there you go. Good, all right. As long as I'm not going completely insane and getting the wrong end of the stick. Brilliant. Excellent. Well, I will let you go back and have your Saturday night. Dr. Karas over here is saying thank you, brilliant conversation.
Thank you, Karis.
And I will speak to you soon, and I will end this here on Instagram, and I will speak to you as well at a later date. Thank you.
Thank you. Thank you, everyone who joined. Thank you.